I'm going to speak about women and diabetes, and there's estimated 204 million women living with diabetes, and this number is projected to increase to 308 million by 2045, according to the International Diabetes Federation Atlas. 1 in 3 women with diabetes is in the reproductive age, and diabetes is the 9th cause of death in women globally, causing 2.1 million deaths yearly, and 1 in 7 births are affected by gestational diabetes, and this is the International Diabetes Federation saying that diabetes is the 9th leading cause of death in women globally, and women have the right to a healthy future. Those nice females making exercise and wearing blue color, which is characteristic of the World Diabetes Day, these ladies have the right to a regular uninterrupted supply of insulin and blood glucose testing equipment and test strips and other anti-diabetic medications, and they should adopt a healthy lifestyle. These are the diabetes complications, and diabetes is known to cause end-stage renal disease, and in diabetes, it is 10 times higher than in non-diabetic population, and every 30 seconds, a lower limb or a part of a lower limb is lost due to amputation due to complicated diabetes. People with diabetes are 2 to 3 times more likely to have cardiovascular disease, and gestational diabetes has an effect on both mother and children. And diabetes is the leading cause of sight loss in most of the working age adults. It is the most important cause in working age adults. One in 6 live births is affected by hyperglycemia in pregnancy. I'll start to talk about diabetes and pregnancy, and diabetes and pregnancy is either a preconception diabetes or a gestational diabetes. And the pre-gestational diabetes is a pregnancy occurring in a pre-existing diabetes, whether type 1 diabetes or type 2 diabetes, while gestational diabetes is diabetes diagnosed to the first time during pregnancy. And let's start with the preconception diabetes. When we see the natural history of diabetes with pregnancy, about 50 years ago, 2% of women with diabetes died during pregnancy, 10% of babies born as stillborn babies, and 10% of babies died during the first months of life. While starting from 1980s, evidence of good preconception diabetes control improved the outcome. Studies in 1990s said that if the conception hemoglobin A1C is more than 10%, there is going to be a prevalence of congenital malformation about 10%. If the conception hemoglobin A1C is less than 7%, the congenital malformation rate is that of the general population. And this graph showed that when the hemoglobin A1C is higher, reaching more than 14 gram percent, we will find the abnormalities maximum. So glycemic control preconception is When we manage pregnancy in diabetes, there should be a preconception clinic, which is lacking in our country, and we should start to ask for a preconception clinic. And at the preconception clinic, we should stress on the preconception hemoglobin A1C to be less than 7%, and to stop teratogenic medications, for example, ACE inhibitors, and to stop smoking, to start folic acid 5 milligram 3 months before pregnancy, and to test for rubella status, and to switch to insulin if on oral agents. Again, we should do a retinal screening and to discuss with the patient the potential deterioration in retinopathy and nephropathy during pregnancy. And to make a schedule of care in pregnancy with the patient, and to test for albumin creatinine ratio. And if it is positive, we know that there is increased incidence of preeclampsia in these patients. During the prenatal care, women should be encouraged to monitor their blood glucose regularly, better to do before and after each meal. And we need to do an optimal glycemic control in pregnancy for pre-existing diabetes through individualized insulin therapy by basal bolus insulin. And the basal bolus may be insulin, Aspart or Lispro for the bolus, or if not available, we can use the regular insulin. And for basal insulin, we can use the Deteriorating or Glargine. And to encourage the patient for SMBG pre and post-prandially. These are the target glucose control according to the Canadian Diabetes Association. And the fasting blood glucose to be around 95 milligram, 1 hour postprandial blood glucose to be less than 140, and 2 hours postprandial blood glucose to be less than 120. These are very difficult to obtain figures, and very strict control is needed for gestational diabetes or pre-gestational diabetes. According to the American Association of Clinical Endocrinology and the American Diabetes Association guidelines, these are the glucose glycemic control needed for patients with gestational diabetes. The preprandial or pre-meal blood glucose should be less than 95. The postprandial 1 hour less than 140, and 2 hours less than 120. For patients with pre-existing type 1 or type 2, the numbers should be lower than patients with gestational diabetes with a preprandial blood glucose or bedtime blood glucose and overnight glucose to be between 90 and between 60 and 99, which is very difficult to obtain. The peak postprandial glucose to be between 100 and 129, and the hemoglobin A1C to be equal or less than 6%. These figures are very strict, and we know all that they are very difficult to obtain. Hypoglycemia should be discussed, and glucagon should be available with the pregnant diabetic lady with clear instruction how to use the glucagon. Full retinal assessment should be taken in all women with pre-existing diabetes during the first trimester. These are the causes of hypoglycemia during pregnancy. There may be pathophysiological causes due to fetal absorption of glucose from the maternal bloodstream via the placenta, particularly during periods of maternal fasting. history of severe hypoglycemia before pregnancy, impaired hypoglycemia awareness, longer duration of diabetes, hemoglobin A1C equal or less than 6.5 at first pregnancy visit, and high daily insulin dosage. There are some iatrogenic hypoglycemia in the form of administration of much insulin or other anti-hyperglycemic medication, skipping meals, or exercise. The clinical consequences of hypoglycemia, there are some signs of hypoglycemia, anxiety, confusion, dizziness, headache, hunger, nausea, palpitation, sweating, tremors, warmth, and feeling of weakness. And there is complicated hypoglycemia by coma, by traffic accident, or even death. And severe hypoglycemia can lead to maternal seizure or hypoxia. And management, we can at first inform the patient with increased risk of severe hypoglycemia, how to deal with hypoglycemia, and to educate the patient on hypoglycemia prevention and how to do SMBG frequently, regular meals, adequate medication or accurate medication administration, and careful exercise programs. And this is the management of hypoglycemia when hypoglycemia is suspected or confirmed, and confirmed is hypoglycemia with blood glucose less than 60 milligram per deciliter. We have either severe hypoglycemia when the patient cannot swallow, and mild to moderate hypoglycemia when the patient can swallow. If the patient is having severe hypoglycemia, we can give 1 milligram glucagon injected subcutaneously, and emergency assistance is required. After 15 minutes, if the patient is improving, then we will start to give the patient a snack, and the patient will regain consciousness. In case of mild to moderate hypoglycemia, the preferred treatment is 15 to 20 grams of glucose. As an alternative, she can drink half a cup of juice or 1 cup of non-fat milk. After 15 minutes, recheck the SMBG. If the hypoglycemia is resolved, then we can do the blood test to be confirmed, and to give a snack or a meal to prevent recurrence of hypoglycemia. If hypoglycemia is not resolved, we can repeat the treatment by the oral glucose or oral fluid containing sugar. During managing diabetes with pregnancy, the retinal screening should be done every trimester if there is no retinopathy, and if there is retinopathy, we should refer to an ophthalmologist for surveillance. Deteriorating retinopathy is expected due to vasoactive or angiogenic factors. Creatinine and albumin creatinine ratio should be measured in early pregnancy, and if approved, to be tested every trimester. Most deterioration in nephropathy is reversible, and microalbuminuria usually doubles the risk for preeclampsia. During the prenatal care, all women should be referred to ultrasound, and this is usually made by the obstetrician, and all should be offered detailed anomaly ultrasound between 18 and 22 weeks. Serial ultrasound during the 3rd trimester to monitor the fetal growth. This is the job of the OB/GYN consultant. And if delivery is indicated before 34 weeks, Administration of glucocorticoid will be considered to prevent neonatal respiratory distress syndrome, and this corticosteroid is expected to make the blood glucose more higher, and maybe change in the insulin dose will be required. During labor, no full-term delivery is required. Usually, obstetrician induce delivery before 38 weeks of gestation. Intravenous dextrose and insulin should be administered during labor, and it will need a multidisciplinary protocol between the obstetrician and the endocrinologist. Care of the baby, usually with a neonatology consultant, and babies should do a blood glucose test repeatedly, and hypoglycemia is diagnosed with glucose testing with an electrode or laboratory method, and hypoglycemia managed by an neonatology consultant. These are the problems in pregnancy. For a diabetic lady, these are known problems which start with difficulty in conceiving, with very poor control diabetic, increased first trimester miscarriage rate, macrosomia, polyhydramnios, obstructed labor, shoulder dystocia, birth injuries, unstable lie, cord prolapse, preterm labor. Placental insufficiency during the third trimester with hypoglycemia sometimes, and preterm delivery, preeclampsia, increased risk of infections, GKA, which may be fatal to the fetus, neonatal hypoglycemia. Again, these are some unpleasant problems during pregnancy. Increased incidence of intrauterine deaths, particularly after 36 weeks of pregnancy, may be due to chronic hypoxia, hyperglycemia, and lactic acidosis. No pregnancy with pre-existing diabetes should go more than 40 weeks, and usually most obstetricians aim to deliver the patient between 38 to 30 weeks of pregnancy. Let me now speak about the gestational diabetes, and gestational diabetes, does it matter? Yes, there is some fetal abnormalities like high birth weight or small for gestational age, macrosomia, hypoglycemia, dysmature baby, respiratory distress syndrome, birth defects, preeclampsia, and mothers with gestational diabetes will become type 2 diabetic patients in 50% of cases later. Childhood obesity and type 2 diabetes for large babies later during life. When to screen for gestational diabetes? In ladies with previous gestational diabetes, in persistent glycosuria, previous large baby's history, more than 4 kilograms birth weight, current large baby, more than 95th percentile, polyhydramnios, first degree relative with diabetes, previous unexplained stillbirth, polycystic ovary syndrome, BMI of the mother more than 35, and some ethnic groups. What to do for the postpartum care of the gestational diabetes? 6 weeks after the delivery, we should repeat the 75 oral glucose test to exclude ongoing diabetes mellitus or impaired glucose tolerance. And there is an opportunity to reduce the risk of type 2 diabetes and also to screen for type 2 diabetes. Let me finish with this lovely lady. She had gestational diabetes and she received insulin, and thank you.